Good morning. My name is Monica Quinn, and I'm the Director of Pharmacy Operations for West Cancer Center. And I would like to thank the event coordinators for inviting me to speak at today's conference. Today, I will be presenting on solid tumor pharmacy updates. And as far as updates go, I want to look at any new drug approvals within the last year. So within the last year, there have been about 8 new drug approvals, and we'll go through each one of them. The first class I will cover are the monoclonal antibodies. And this year we have had 2 monoclonal antibodies. The first one is toripalimab, and it is an anti-PD-1 monoclonal antibody. And it works on the PD-1 pathway by inhibiting the binding of programmed cell death receptor 1 to its ligands, PD-L1 and PD-L2, leading to T-cell activation and anti-tumor response. Toripalimab was indicated in the treatment of adult patients with metastatic or recurrent locally advanced nasopharyngeal carcinoma in combination with cisplatin or gemcitabine, or as a single agent therapy for adult patients with recurrent, unresectable, or metastatic nasopharyngeal carcinoma with disease progression on or after platinum-based chemotherapy. It was evaluated in the Jupiter-02 phase 3 trial, and this trial studied extensive progression-free survival. So the toripalimab plus chemotherapy arm showed a better progression-free survival than placebo plus chemo arm. The most common adverse reactions with toripalimab include fatigue, hypothyroidism, and musculoskeletal pain. And when it's combined with gemcitabine and cisplatin, the most common adverse reactions include nausea, vomiting, decreased appetite, constipation, hypothyroidism, rash, pyrexia, diarrhea, peripheral neuropathy, cough, musculoskeletal pain, upper respiratory infection, insomnia, dizziness, and malaise. There was about a 12% discontinuation rate in the trial and a 50% dose reduction rate in the trial when it was combined with gemcitabine and cisplatin. Toripalimab is dosed at 240 milligrams every 3 weeks when it's used in combination with gemcitabine and cisplatin, and it is infused over 60 minutes for the first infusion, and then subsequent infusions can be given over 30 minutes if there were no infusion-related reactions during the first infusion. As a single agent, it is dosed at 3 milligrams per kilogram on cycle 1, day 1, every 14 days, and this can continue until disease progression or unacceptable toxicity. Toripalimab should be withheld or permanently discontinued for grade 3 or 4 immune-mediated or infusion-related reactions. Tislelizumab is also an anti-PD-1 monoclonal antibody. It's indicated in the treatment of unresectable or metastatic esophageal squamous cell carcinoma after prior systemic therapy that did not include a PD-1 inhibitor. It was evaluated in the Rationale 302 phase 3 trial, and tislelizumab improved overall survival in all patients with a median overall survival of 8.6 months versus 6.3 months in the chemotherapy arm. The most common adverse reactions with tislelizumab were increased AST, anemia, and hypothyroidism. Tislelizumab is dosed at 200 milligrams once every 3 weeks until disease progression or unacceptable toxicity. It is infused on the first cycle 1, day 1, over 60 minutes as an IV infusion, and subsequent infusions can be given over 30 minutes if there are no infusion-related reactions. Tislelizumab should be withheld or permanently discontinued for grade 3 or 4 immune-related or infusion-related adverse reactions. The next class of drugs that I'll cover is kinase inhibitors. There were several kinase inhibitors approved within the last year. So the first one is fruquintinib, and fruquintinib is a potent, highly selective molecule of kinase inhibitor of VEGFR1, 2, and 3, which leads to inhibition of VEGF-mediated endothelial cell proliferation, tubular formation, VEGF FR2 phosphorylation and tumor growth. It's indicated in the treatment of adult patients with metastatic colorectal cancer who have been previously treated with fluoropyrimidine, oxaliplatin, or irinotecan-based chemotherapy and anti-VEGF therapy, or if medically appropriate, and EGFR therapy. It was evaluated in the FRESCO-02 study as well as the FRESCO study, but for the purpose of this presentation, we'll talk about the results of FRESCO-02 study. The overall survival was the major efficacy outcome of both studies, but the median overall survival was 7.4 months for those treated with fruquintinib versus 4.8 months in the placebo group. The major adverse reactions for fruquintinib include hypertension, palmoplantar erythrodiodesis, and proteinuria, as well as dysphonia, abdominal pain, diarrhea, and asthenia. Fruquintinib is dosed at 5 milligrams once a day with or without food for the first 21 days or in a 28-day cycle. This drug should not be initiated unless the patient has an adequately controlled blood pressure, and it should be held for greater than 2 weeks prior to or after a major surgery to allow for wound healing. Drug interactions include strong or moderate CYP3A inducers. So that should be taken into mind when patients are prescribed this medication. You want to try to avoid concomitant use of both drugs, or if possible. The next drug is repotrectinib. It is a multi-kinase tyrosine inhibitor of ROS1 and NTKR gene fusion. It is indicated for the treatment of adult patients with locally advanced or metastatic ROS1 positive non-small cell lung cancer. It was evaluated in the Trident-1 study. This study confirmed overall response rate in the ROS1 TKI naive group, which was 79% versus 38% in those patients receiving prior treatment with a ROS1 inhibitor. The most common side effects with repotrectinib is dizziness, dysphagia, peripheral neuropathy, constipation, dyspnea, fatigue, ataxia, cognitive impairment, and muscle weakness. Repotrectinib is dosed at 160 milligrams once daily for 14 days, and then increased to 160 milligrams twice daily. And it's continued until disease progression or unacceptable toxicities. Drug interactions with this drug include strong or moderate CYP3A inhibitors, inducers, certain substrates, as well as hormonal contraceptives. The next drug is capivasertib, and this drug is a AKT tyrosine kinase inhibitor. It's indicated in the treatment of adult patients with hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer with one or more PIK3CA, AKT1, or PTEN alterations following progression on at least one endocrine-based regimen in metastatic setting, or recurrence on or within 12 months of completing adjuvant therapy in combination with fulvestrant. This was evaluated in the Capelto 219 trial. The major efficacy outcome was investigator-assessed progression-free survival in the overall population and in the population of patients whose tumor had PIK3CA, AKT1, or a PTEN alteration. This showed improved progression-free survival in patients with either of these alterations. The most common adverse reactions were diarrhea, cutaneous adverse reactions, hyperglycemia, anemia, hypertriglyceridemia, fatigue, nausea, vomiting, or stomatitis. Capivasertib should be dosed at 400 milligrams twice a day for 4 consecutive days, followed by 3 days off. It is given in combination with fulvestrant and continued until disease progression or unacceptable toxicity. Drug interactions with capivasertib include strong or moderate CYP3A inhibitors or inducers. The next drug is in a class of its own, and it's a gamma secretase inhibitor. It's nirogacestat, and this drug is the first drug approved for desmoid tumors. It's indicated in adult patients with progressing desmoid tumors who require systemic treatment. It was evaluated in the DeFi trial, and the major efficacy outcome measure was progression-free survival. I do want to make note here that the median progression-free survival was not reached in the nirogacestat arm, and it was 15.1 months in the placebo arm. The major adverse reactions were diarrhea, ovarian toxicity, rash, nausea, fatigue, stomatitis, headache, abdominal pain, cough, alopecia, upper respiratory tract infection, and dyspnea. Nirogacestat should be dosed at 150 milligrams twice a day until disease progression or unacceptable toxicity. Drug interactions include strong or moderate CYP3A4 inhibitors, inducers, certain substrates, and gastric acid reducing agents, as well as certain CC19 substrates. The next drug we'll cover is nacobendekin alpha and bacacil, or NAI for short. It is an interleukin-15 receptor agonist. It is indicated in the treatment of BCG unresponsive, non-muscle invasive bladder cancer with carcinoma in situ with or without papillary tumors. This drug was evaluated in the QUILT 3.032 trial. The major efficacy outcome measure was complete response at any time and duration of complete response. The complete response rate achieved was 62%, and 58% of those patients with complete response had a duration of response of 12 months or greater. Some of the most common adverse reactions include increased creatinine, dysuria, hematuria, urinary frequency, micturition urgency, urinary tract infection, increased potassium, musculoskeletal pain, chills, and pyrexia. NIA is dosed at 400 micrograms during induction intravesically with BCG once a week for 6 weeks. The induction may be repeated if a complete response is not achieved at month 3. Maintenance dose is 400 micrograms administered intravesically with BCG once a week for 3 weeks at month 4, 7, 10, 13, and 19 for a total of 15 doses. Ongoing maintenance, if a complete response is achieved at 25 months or greater, is 400 micrograms administered intravesically with BCG once a week for 3 weeks at months 25, 31, and 37 for a maximum of 9 additional installations. And the maximum total duration of this treatment should be 37 months. The treatment should be discontinued if disease persists after the second induction or with progression or unacceptable toxicity. The next class of drugs is a bispecific monoclonal antibody. Tarlatamab is a first-in-class approved drug. It is a bispecific T-cell engager that directs T-cells to cancer cells expressing delta-like ligand 3. It is approved in the treatment of adult patients with extensive stage small cell lung cancer with disease progression on or after platinum-based chemotherapy. It was studied in the Delphi 301 trial, and the primary outcome measure was overall response rate, which was 40% at the 10 milligram dose. The most common adverse reactions of tarlatamab include cytokine release syndrome, fatigue, pyrexia, dysphagia, decreased appetite, musculoskeletal pain, constipation, anemia, and nausea. This drug does have a box warning for CRS and neurologic toxicity, including immune effector, cell-associated neurotoxicity syndrome. Tarlatamab is administered as an IV infusion over 60 minutes. Patients receive 1 milligram on cycle 1, day 1 as a step-up dose, and that's followed by a 10 milligram dose on cycle 1, day 8 and cycle 1, day 15, which is followed by a 10 milligram dose every 14 days thereafter until disease progression or unacceptable toxicity. It should also be given with 8 milligrams of IV dexamethasone or an equivalent, which should be administered 1 hour prior to cycle 1 day 1 and cycle 1 day 18 treatment. Patients should receive 1 liter of IV normal saline over 4 to 5 hours immediately following the completion of tarlatamab on cycle 1, day 1, day 8, and day 15. From the start of their cycle 1, day 1, and cycle 1, day 8 infusions, patients need to be monitored or observed for 22 to 24 hours due to the risk of developing CRS. And it's recommended that observation time decreases with subsequent cycles. Next, I'll cover the FDA approval for new indications that came about in 2024. Erfitinib and nivolumab both received new indications in the urothelial carcinoma space. Mirvetuximab received a new indication in ovarian, fallopian tube, and peritoneal cancer. Trastuzumab received a new indication in solid tumors. Alectinib received a new indication in non-small cell lung cancer. Repotrectinib received a new indication in solid tumors with NTRK gene infusion. Durvalumab received two new indications in non-small cell lung cancer as well as in endometrial cancer. Pembrolizumab received 2 new indications in endometrial cancer and malignant pleural mesothelioma. Amivantamab received a new indication in non-small cell lung cancer. Adagrasib received a new indication in colorectal cancer, and ribociclib received a new indication in breast cancer. And finally, we have the FDA withdrawals of accelerated drug approvals in 2024, and we had 2 withdrawals for 2024. They were mobocertinib, which was previously approved for locally advanced or metastatic non-small cell lung cancer, and then infigratinib, which was previously approved for previously treated unresectable, locally advanced, or metastatic cholangiocarcinoma. And that ends my presentation. I do want to say that there are several drugs for oncology in the pipeline, and I look forward to the new drug approvals in the pharmacy space and oncology. Thank you all for your time. Have a great day.